All right, it seems like we have almost everyone in who's going to be joining, so I want to get started here. Firstly, I want to thank everyone for donating to see the talk and for being here to see Dr. Diamantoni. He is the Lancaster County Coroner and has served in that position since 2008. He is board certified in forensics and family medicine, as well as a practicing family physician who began his own medical practice in 1985. He is also a fellow of the American Academy of Family Practice. So he will be getting here in a second. And if you have any questions for him, please put them in the chat. If your video is not off or if you are not muted, please do that now. And we'll get started here. Dr. Diamantoni, take it away.
Great. Hey, thank you very much for having me. As you mentioned, I've served as coroner since 2008, and I still continue to practice medicine full-time as well. First, I want to give a little background on what I'm doing as the coroner. To be honest with you, until I took office, I wasn't completely sure of all the responsibilities of the coroner either. But the most important thing to know is that the coroner is required to investigate deaths that are sudden and unexpected, or any that fall into the jurisdictional realm, which includes accidents, homicides, suicides, and deaths where the etiology of the death is uncertain. The coroner is an elected position. I run for office every 4 years. Interestingly, there are no prerequisites to the position, so you don't need a certain educational background. Lancaster County is unique because I think for over 100 years, the coroner has been a physician, but that really is not the case for most counties across the state. The 67 counties that have either coroners or medical examiners, only 5 are physicians, and the others have a big combination of backgrounds, be it funeral directors or people in law enforcement, or people who just are interested in being the chief death investigator in whatever county they're in. Obviously from my point of view, I think because many deaths are complex and because the investigations often involve review of medical records, I think being a physician offers a tremendous advantage in terms of being able to do the job well, but certainly isn't the case across the county. Across the Commonwealth. Again, the most important thing that we do is determine cause of death and manner of death. And in doing this, we do scene investigations. If we get called out to a scene, if someone has died suddenly or unexpectedly or as a result of the accident, in addition to viewing the decedent, we look at the entire scene. We interview people who may have been around the death or may have something to some knowledge of how or why the death occurred. We photograph everything in detail, and depending on the circumstance, we'll either bring that individual back to the forensic center or end our physical investigation at the scene and allow disposition to the funeral home or wherever the decedent's family would like us to take the decedent. If we're not certain of cause of death or manner of death, we have other tools at our disposal. Certainly, one option, if we're uncertain, would be bringing people in for autopsies, and we'll do that in a certain number of cases. We'll also autopsy criminal cases so that the prosecution has evidence that they can use at the time of trial. But generally speaking, when we're doing autopsies, we do it to try to clarify exactly what the cause of death or the manner of death of an individual is. We also are fairly unique. We're one of only a couple of jurisdictions in the Commonwealth that have a CT scanner at our disposal. The CT scanner was very generously donated from Lancaster General Hospital, and we've used it pretty extensively. We're not really doing virtual autopsies as a rule, but when we're looking for something significant or something that would explain why an individual died, that may either help guide us in the autopsy or help us choose not to do an autopsy, we'll end up using a CT scanner. For example, if someone has multiple gunshot wounds, we'll use the CT scanner to identify where the projectiles are. If someone appears to have had a natural death and falls and hits their head, rather than subjecting them to an autopsy and opening up their head to look inside to see whether they had a bleed, which would make it an accidental death rather than a natural death, we may CT their head and help make that determination. So it's been incredibly, incredibly helpful. And, we're deeply appreciative of Lancaster General for donating their old CT scanner to us. I guess the question is, why are we involved in the deaths of individuals who may have passed from COVID? And that's actually a requirement of the law, because the law stipulates that the coroner is to have all deaths from infectious diseases that pose a public health hazard to be reported to our office. Interestingly, that doesn't mean we have to bring everyone in. It doesn't mean we even have to delve deeper than reviewing some of the death certificates to confirm that all that information that's necessary to confirm that was a COVID death is there. Though there are many times that we do scene investigations, and there are many times that we do additional testing to confirm an individual has died as a result of COVID. And as such, I think we are very accurate in our reporting. And, we can share that information with the media or general public or anyone who's interested in that information, and have done so throughout the pandemic. I mean, interestingly, I still get calls from Lancaster newspaper on a daily basis asking how many people have died of COVID. So, we continue to supply that information. Interestingly, we've had varying guidance from the State Department of Health. And the State Department of Health has had been all over the place during the pandemic in terms of what they wanted to do with reporting. Initially they said, well, we want all confirmed cases reported. Then they said, well, in a nursing home, if someone else died of COVID and they were in close proximity to someone, we'll look at that as being a presumptive death. Then they had said, well, we've changed our mind again. We don't want to count that as a presumptive death. We'll let our statistician figure everything out at the end. We weren't comfortable with that. We wanted to be sure that the information that we report was very, very accurate. So what we did is sent our death investigators to all the scenes where somebody had died and in which COVID had not been, confirmed by testing, and sent all our people in with personal protective equipment. And we tested each and every one of those individuals. So if people had a clinical picture that looked like COVID, had the symptoms of COVID, had been in contact with someone with COVID, we went out and did testing on all those individuals and did not report it as a COVID death unless we knew with certainty that that individual tested positive with COVID and had a symptom complex that was consistent with COVID. That causes us to really feel very confident in what we have and the information that we're able to provide the public. There had been some discrepancies between our office and the Department of Health. And some of those discrepancies were that they had some delay in reporting, and their reporting was different. They reported everyone who may have died outside the county, but as a county resident, is one of the deaths of the county. Our numbers were real time. They include all the individuals that ended up dying in Lancaster of COVID illness. And to date, we have, as of yesterday, 1,283 people have died in Lancaster County as a result of the COVID virus, which is a unbelievably large number. And we're seeing a little bit of surge right now because there was a bump in the total number of cases, and usually a week or two after that bump in cases occurs, we end up identifying a significant increase in the number of deaths. So who's at risk to die? And most of you probably know this information, but I think it bears repeating. The biggest determinant is age. I mean, if you look at individuals who are 65 and over, individuals 65 and over account for 75% of the total deaths from COVID. 21% of those deaths are in individuals between the ages of 45 and 65, and only 4% are in individuals less than 45. Overall, in terms of race, 63% of the people who died of COVID are white, 17% are Latino, and about 15% are Black. Now, interestingly, this is for adults. If you look at the pediatric population, it's a little bit different. The kids that die of COVID, being Latino or Black, puts them at a much greater risk than being white. Some of the factors that come into play that cause that are uncertain. You know, we're still continuing to learn more and more about the virus. If individuals are over age 80, they have an 11-fold increased risk of death. So, you know, certainly the older you are and the more risk factors that you have, the more likely you are to die of the virus. I mean, in terms of risk factors, in addition to age, big risk factor is obesity. People who have BMIs of over 30 are at particular risk. Talking to nurses who work in the ICUs that are managing individuals with COVID on ventilators, almost all of them are obese. Almost all of them are obese. So in addition to getting the disease, the people who could become very sick and die as a result of the disease have a higher likelihood of being obese. Once an individual is also diabetic or even develops glucose intolerance, that increases their risk as well. Also, any other chronic medical condition, be it congestive heart failure, lung disease like chronic obstructive pulmonary disease or emphysema, chronic kidney disease, any of the chronic illnesses are going to increase that individual's risk. And interestingly, if somebody is male gender, if you happen to be male, your risk is going to be higher of not only contracting the disease, but also dying from the disease. And the reasons for that also remain unclear. People who have an type A blood type are at higher risk. People who have type O blood type tend to be lower risk. The reason for that also is unclear. And also, you know, people who have low vitamin D levels also creates a much greater risk for those individuals. You know, the place people die has changed quite a bit over the last year and a half. At the beginning of the pandemic, the majority of people who died died in nursing homes, interestingly. And you know, and as many of you are aware, many of the nursing homes were decimated as a result of the COVID virus. I mean, there were places that we would enter, and the nursing home would have a unit of, say, 42 dementia patients, and we'd come in to pronounce and certify deaths of several of those individuals. But we looked around and recognized that a lot of the other individuals within that unit were also very, very sick and were at risk for dying as well. And there were times that the entire unit, 40 people would end up dying as a result of the COVID in a very short period of time. At this point, the percentage of deaths really are most likely to occur within the hospital. I think overall, about 85% of COVID deaths occur in hospitals. About 10% occur in extended care facilities like nursing homes, and only 6% of individuals die at their home. The other thing to know is if people have severe COVID infections and develop damage to their organs as a result of COVID, the likelihood that they die within the next 12 months is double the average population. And this isn't surprising because a lot of the sequelae of COVID include damage to the lungs, damage to the kidneys, damage to the heart. So sadly, people who are already compromised are going to be much more compromised as a result of the illness. To just get something off my screen. Sorry about that. The vast majority of people who die in hospitals at this point, and remember, the vast majority die in hospitals, and the vast majority of those individuals who die in the hospital die in the ICU. Exceptions to that are people who are very ill and whose family don't want them to be aggressively treated. You know, if they have a do not place on a ventilator in their post, you know, they may be simply made very comfortable and allowed to continue to die. Many of those individuals can be discharged from the hospital and sent home in hospice care. But the majority of the people who die in the hospital die in the ICU, and are in the ICU oftentimes for very long periods of time. What puts them at risk of dying when they're in the ICU? I mean, all the risk factors that we previously talked about. You know, they tend to be obese. They tend to be older. They tend to have multiple comorbidities. I mean, there's certainly exceptions to that. There are people who are a bit younger and don't have those comorbidities who end up in the ICU, but the majority of them end up in the ICU. And actually, you know, at this point, probably 80 to 90% of the people in the ICU are people who are not vaccinated. And just about 100% of the people in ventilators are the people who are not vaccinated. So, you know, obviously as a family doctor, and I think all the other physicians probably are tuning in and are feeling the same way, we're oftentimes frustrated at our inability to convince everybody about the safety of the vaccine and the efficacy of the vaccine. The people who work in the hospital and the people who are practicing medicine see it. We all see it all the time. Any severe dysfunction on admission. So if people have problems with renal insufficiency, if people have a chronic congestive heart failure, people have problems with their lungs, it's going to significantly increase the likelihood that they'll die in the ICU. The other thing is for the doctors in the group, labs that show increase in inflammatory markers will also significantly increase the risk of death. You know, people who have increased troponin levels, which is a marker that oftentimes is seen in people who have damage to their heart, you know, low white blood cell counts, increased liver function test, increased CPK levels, which is a muscle enzyme that can be released in the system, and certainly decreased kidney function. All those things will increase death of those individuals. Probably the biggest disease process that results in death of people overall with COVID is adult respiratory distress syndrome. This is a condition that develops where the alveoli, which are the little air sacs in the lung that are responsible for oxygen exchange and oxygenation of our blood, begin fill with fluid and start to collapse. And in addition, the substance of the lung itself, the interstitial part of the lung itself, also becomes very wet and filled with fluid. And this happens not immediately. I mean, oftentimes people develop the COVID infection, they have, you know, moderate symptoms or mild symptoms, and 6 days or so after development of those symptoms, they begin to develop some shortness of breath. And that's why really we encourage anybody who's at home being treated with COVID, if they start getting short of breath or their oxygen level drops, they really need to be immediately evaluated in an emergency department setting to be sure that they're not developing adult respiratory distress syndrome. Even though it's a few days, it's 5 or 6 days in developing, oftentimes after that, if people develop it, it develops pretty rapidly. In the next 2 or 3 days, people can go from, you know, having normal oxygen levels and a little short of breath to needing to be placed on a ventilator. You know, once they're placed on a ventilator, their mortality is very, very high. The need for ventilation varies between institutions. And the reason it varies is people have different criteria of when they think it's appropriate to put people on a ventilator. You know, some institutions report that the need for a ventilator in someone who develops ARDS is 20-25%. In some institutions, they believe it's 80 to 90%. But once people are placed on a ventilator with ARDS, the likelihood that they'll survive drops to about 50%. And you know, the sad thing is, for a lot of those individuals who need to be sedated and who are placed on a ventilator, you know, the last conversation they may have with anyone is with the hospital staff right before they're intubated and placed on a ventilator. What happens in those individuals and why do they develop such problems with their lungs? in some individuals, in many individuals, the COVID virus causes a huge release of inflammatory substances. I mean, those substances are cytokines, and these cytokines cause tremendous amount of inflammation of the lungs and also inflammation of other organs that predispose to multi-organ failure in those individuals. And in adult respiratory distress syndrome, even with ventilatory support, those individuals oftentimes don't have adequate amount of oxygen entering their system. So they don't have enough oxygen going to their brain, but they also don't have enough oxygen going to their kidneys, to their gut, and to all their vital organs. And, in addition to, the lungs being very wet as a result of ARDS, as time goes on, the condition evolves, and the effect of a lot of these inflammatory substances is to actually cause scarring of the lungs. So the lungs, in addition to being a little difficult to ventilate when individuals start with the condition, because of the fluid in the lungs and because of the difficulty in overcoming a lot of the fluid that's actually in the tiny airways, it gets worse and worse with time as the lungs become fibrotic and scar tissue starts to develop in the lungs. The challenge is that for a lot of individuals, this mechanical ventilation causes irreversible damage, and we call that barotrauma, where large amounts of pressure in those airways actually cause direct damage. So we already have a very damaged lung as a result of COVID, and the things that we're doing to save the lives of those individuals also end up contributing to a lot of damage. The amount of PEEP, which is the peak end expiratory pressure, or the amount of pressure between breaths that the ventilator has to deliver, is high, and the amount of pressure even to expand the lung is very high. So in addition to damaging the airways, sometimes the lungs can actually kind of spring a leak and collapse the entire lung. That's called a pneumothorax. Those individuals may need chest tubes in order to survive. So they have a bad situation, and the bad situation gets even worse. Sometimes, because of the severity of the disease, even the ventilator is not going to be adequate in providing oxygen. So their oxygen levels are dropping. So the next step for a lot of those individuals is something called Ecmo, which is extracorporeal membrane oxygenation. For those non-docs in the group, basically what that is putting someone on a heart-lung machine. So the lungs are bypassed, and oxygenation occurs, without without needing to get that oxygen exchange occurring at the lungs. Ecmo, again, may be necessary to maintain oxygenation, but it has lots of risks. Blood clots and strokes and all kinds of problems associated with Ecmo. And honestly, the survival, once people are placed on Ecmo, is very low. We had one of my nurse practitioners in the office worked as a head nurse in the ICU at Hershey and managed a lot of those patients. For a number of months, everybody on Ecmo died. I mean, that's how high the mortality is. More recently, people are surviving, but the only reason more people are surviving is some of the people being placed on Ecmo, sadly, are younger individuals, and their bodies are a little bit more resilient. The other challenge in the ICU setting is individuals become agitated and fearful, and delirium actually occurs in about 65% of individuals. So the vast majority of people, in order to relax them for the ventilator, or if they develop delirium and they become rammy and difficult to control, not trying to pull their breathing tubes out, need to be sedated and they need to be paralyzed. And unfortunately, the sedation and paralyzing individual increases the risk even further. It increases the risk that they'll end up developing blood clots that can go to their brain or other parts of the body. We talked about decreased kidney function being a risk factor for severe disease. Sadly, if people develop ARDS, they develop additional kidney damage. And this is due to either decreased blood flow to the kidneys, because sometimes medications need to be used to increase the blood pressure of individuals who are critically ill in the ICU as a result of the COVID virus. They can have decreased oxygenation of the kidney, which causes damage, and also this release of the inflammatory substances, the cytokines, worsens the disease as well to their kidneys. So fully like 20 to 40% of people, end up having severe kidney injury who are in a ventilator in the ICU because of the ARDS. And a lot of those individuals need either dialysis or of either peritoneal dialysis or hemodialysis or what they call now chronic renal replacement therapy. For those who might not be familiar, it's almost like dialysis, but rather than doing it for a short period of time, and do it for an ongoing period of time to be a little gentler on the system. But unfortunately, once you hit that point where you need dialysis or some type of kidney replacement therapy, the mortality for those individuals goes up by to about 50%. So that in itself, end up having kidney damage, portends a very poor prognosis and results in the death of many of those individuals. In addition to the kidneys and the lungs, other organs are involved too. The gastrointestinal system can be involved. People develop a condition called acute pancreatitis. The pancreas, in addition to producing insulin for the system, also produces a lot of digestive hormones. And those hormones are very, very caustic and destructive. So when the pancreas becomes inflamed as a result of the condition, pancreatitis itself can result in death. About 4% of the population in the ICU gets something called mesenteric ischemia. The mesentery is the supporting structures that support the intestines. And this occurs 4% of individuals. If you develop mesenteric ischemia to the point that you lose a portion of your gut and need surgery, again, your mortality is 40 to 50% from that. There's all types of cardiac manifestations as a result of the COVID virus. Many individuals develop congestive heart failure, and this could be due to a number of things. It could be due to ischemia or decreased blood flow to the heart. It can also be due to the inflammatory substances directly impacting the heart muscle and decreasing the function of the heart muscle. And of course, if somebody has heart failure on top of the ARDS, things become much more somber and worse for that individual. In addition, because the COVID virus increases the capacity, the clots within the system, people can develop heart attacks. They can become victims of an acute coronary event like a myocardial infarction because clots develop within the coronary arteries, shutting off blood flow to the portion of the heart. And those things in itself can cause death of an individual, either as a result of poor heart function or the result of a fatal arrhythmia that can occur as a result of that. Decreased blood flow to the brain occurs in individuals, as well as decreased oxygenation as a result of the infection. And people develop strokes. People develop hemorrhagic strokes or bland strokes. The hemorrhage can sometimes occur because there are a lot of medications in the ICU that are used to prevent blood clots from occurring in individuals who are at particular risk for blood clots. And those things put individuals at much higher risk for having a brain bleed that could be fatal. Often individuals develop a condition called hypoxic encephalopathy, where the brain is impacted by inadequate amounts of oxygen. And that can occur in conjunction with high levels of the cytokines, causes a lot of those individuals, again, to become confused, delirious, have changes in consciousness. And really that happens in the majority, sadly, majority of people who are in the ICU with COVID infections and ARDS. Just talking a bit, we've talked about adults. As many of you may be aware, children can also be impacted and can die as a result of the COVID virus. I mean, oftentimes we hear parents having discussions that, well, I'm not worried, my kid's not going to be a risk. Only old people with lots of diseases end up dying as a result of COVID. Well, children can die as a result of COVID. And certainly children can also be vectors